For those of you who are lucky enough to not know me, I'm Fred Guzik. I'm on the faculty here at K-State Salina. And I'd like to welcome you folks to our third luncheon lecture. We are excited about today's event and hope you enjoy. If you have not signed in, there's a sign-in sheet at the back and a place to put either your business card or a little slip of paper with your name on it in a fishbowl for a drawing for 2 meals, either to be redeemed before the end of the school year or next September at our next luncheon lecture, if you happen to be around. Our luncheon lecture series is designed to provide students, faculty, staff, and other members of the Salina community opportunities to share food and have conversations on ideas and topics of current relevance. We'd like to thank the Office of the Provost for the Academic Excellence Grant, which supports this lecture series, as well as Kate Chambers and the rest of our food service staff and our faculty and administration for their ongoing support. Regarding today's lecture, our speaker is willing to take questions, and I will wander around the audience with my microphone and repeat your question if you haven't said it loud enough for people to hear it or whatever. So you are welcome to make this a conversation rather than just a lecture. Also, please enjoy your meal if you brought in food. Now I'd like to introduce today's distinguished guest. Linda Shepard holds a Bachelor of Science in Business Administration and a Juris Doctorate both from the University of Kansas. She's Director of the Accident and Health Division of the Kansas Insurance Department and is also serving as Project Manager for the Department's implementation of the insurance provisions of the Patient Protection and Affordable Care Act. Previously, Ms. Shepard was Deputy Attorney General for the Consumer Protection Antitrust Division of the Office of the Kansas Attorney General. She also served as Assistant General Counsel for the Kansas Insurance Department, and prior to joining the department was in private practice with the law firm of Shugart, Thompson & Kilroy, now Posanelli and Shugart in Kansas City, Missouri, specializing in employment discrimination, labor, and construction law. Please welcome Linda Shepard.
Good afternoon. Thank you. I want to make sure this is working. Okay, can you hear me okay? Okay, thanks. As you heard, I am happy to take questions while I'm talking. My presentation style is very informal, and so if I say something that causes you to have a question or prompts you to think of something, please don't hesitate to go ahead and interrupt me, and let's go that way. I always tell people, I'd much rather talk about what you want to talk about. There is so much to talk about as it relates to the Affordable Care Act and what's going to happen over the coming months. And and I never know from audience to audience. I try to predict what it will be of interest to you. But if there's something that you're particularly interested in, I'd much rather talk about that and focus on the things that you care about the most. So I entitled this presentation "The Affordable Care Act: What Happens Now." And after the Supreme Court ruling came out last year that that was one step toward making a determination that this law was going to stay in place. And then following the election in November when the president was reelected, I was commenting earlier that the number of requests that we've had to go out and speak to groups across the state has grown exponentially, starting right after the election, because I think people were still not certain what's going to happen. Is this law going to stay in place? How is it going to change, if at all? Is it going to go away entirely? And I think that people were kind of waiting to see what happens. And once the election got passed and it became clear that this law was going to continue to move forward and be implemented, people now are kind of thinking, well, I guess I need to know what's going to happen. I need to know what's going to be involved in this. So that's what I'm going to try to spend time today talking to you about. What is it that's supposed to be happening over the next coming months and the next couple of years? So I am going to go backwards a little bit, and for some of you that may know some of this already, and I'm going to skim through it really quick, but if you see something up here that catches your attention, let me know, but otherwise I'm going to kind of go through this part really fast. These are the provisions that went into place shortly after the law was enacted in March of 2010. And all of these things, these provisions that are on this slide, and I think the next slide as well, these were things that happened almost immediately. So within about 6 months after the law was enacted, on September 23rd, all of these changes needed to be made in health insurance policies that were being sold across the country, including here in our state. And then there were also some other programs that kicked in. And so it was a real whirlwind right there at the first when they were trying to get a number of these things done in a very short period of time. So a couple of the things that happened, that the no pre-existing condition exclusions for children. So in the past, if you had bought a policy and you had a child that maybe had asthma or had some other pre-existing condition, in the past, the insurance company would have said, okay, we'll go ahead and we'll cover your child, but we may not, we're going to hold off and not cover benefits or services related to that child's condition for some period of time, 90 days, that they wouldn't cover those things. And starting in 2010, the companies could no longer do that anymore, the insurance companies. And that's significant. That practice that we had at the time with that provision coming into place gave us a little bit of insight into some of the concerns that the insurance companies had about what the impact was going to be on that kind of change in the health insurance rules. So prior to 2010, or prior to September 23rd, 2010, we had companies around the state that would sell you what we refer to as a child-only policy. So if you were, if you were a parent that couldn't get coverage for your child through your employer, but you went out and got a policy for yourself, or maybe you were a grandparent or another custodial person responsible for a child, and you could go out and get a policy. When this change kicked in, all of the companies except for one operating in Kansas quit selling child-only policies, because in the past they would be able to pick and choose who they offered this coverage to. And starting in 2010, the regulation that came out from HHS said not only can you not impose pre-existing condition exclusions, but you have to give coverage to every child that applies. And in the past, the companies had not done that. So when they lost that ability to pick and choose which children they wanted to cover, they just decided to get out of the market. And as the insurance regulator for the state of Kansas, we regulate the products the companies sell, but we do not have the ability to tell them what products to sell. I mean, they have to have what they do sell approved, but we had no authority to go to them and say, oh, you must continue to sell this product in the state. So they all except for one backed out. Dependent coverage to age 26, this was another, one of the provisions that was very popular, not only in our state, but across the country. And in Kansas, we didn't actually have a rule about this or a law on the books, but in general, most of the insurance companies in the state would cover a young adult child up until they graduated from college, or around age 23. That was usually when they would say that you couldn't be covered under your parents' policy anymore. So when the ACA kicked into place, that dependent coverage to age 26 went into place, and we had a lot of inquiries, a lot of calls coming into the department, and there were a lot of parents that were very interested in being able to in understanding that their child could stay on their policy if they were getting close to that, getting close to graduating or getting close to age 23. And then for those parents whose child maybe had already aged off, they were very interested in when they were going to get an opportunity to put the child back on the policy. So that's been a very positively responded to provision that was in the law. There was also a small business tax credit program that was put into place for small businesses. Obviously, you can see this is really small businesses, 25 or fewer employees with average wages less than $50,000, and it phases out as you move closer to 25. So from what we can tell, this is probably more helpful if you're around 10 employees and you have those average low wages. That works better. This business tax credit started effective in the 2010 year, so it was you could get up to 35% of your total employer contribution back. And then starting in 2014, and it's only for 2 years, so 14 and 15, you can get up to 50%, and then this tax credit does go away at that time. A couple other things in here, the rescissions issue. This is a situation where if you had somebody had bought a policy and the companies would do something, we refer to it as post-enrollment underwriting, where the company would give you a policy, and then after you started using the policy, and then let's say sometime after you got the policy, you were diagnosed with cancer or had some other serious condition, the company would go back and look at your enrollment form, your application, and try to figure out whether or not maybe you hadn't been quite as candid as you could have been with the answers that you gave on there. And then they would use that as an excuse to not, there's one way of saying, well, they would just cancel the policy. Well, it was worse than that. They would actually view it as being void. So it was like you never had the policy at all. So if they had paid claims for you during that period of time while you had it, it was like you never had it. So you would be responsible for the claims that had been incurred during that time. This was not an issue in Kansas. I'm proud to say that this was not a situation that we had a lot of problems with, but there were other states around the country where there were companies that were engaging in this kind of practice on a fairly regular basis, and there were some horrible horror stories that came out in the media around the time that this provision was being debated. So it does certainly address something that happened. I thought I saw a hand. Is there somebody with their hand up over here? Okay. A coverage of preventive health services with no out-of-pocket. This was another one of the very popular provisions that came out, and it was very widely promoted. The idea being that if you wanted to go out and get your mammogram or your prostate exam or a colonoscopy or any other kind of preventive services that in the past might have been very expensive for out-of-pocket costs with you, starting in 2010, those services needed to be provided without out-of-pocket costs for you. So in the past when you went, maybe you had a co-payment or co-insurance that you had to pay when you got that service. And starting in September of 2010, they could no longer charge those out-of-pocket costs for you. There's some enhanced appeals procedures, and I'll just kind of skip over that. Federal pre-existing condition high-risk pool. And you can see there that that program is no longer accepting participants. This program has been very controversial, and actually we're kind of in a situation right now where this program is very controversial. This was a program that came into place again in 2010, and the federal government, as part of the Affordable Care Act, asked states to take on the responsibility of administering this new federal pre-existing condition high-risk pool, and we call it the PSIP. And you were given the choice, the states were given the choice of running it themselves, or the federal government would do it for you. And in Kansas, some of you may or may not know, but Kansas already has a high-risk pool that has been in existence since the early 1990s. And it's a creation of statute because at some point in the past, in the early 90s, the federal government came out and said, if there are people in your state who cannot get health insurance because of the rules and the underwriting that insurance companies do, you need to provide some sort of mechanism for them to get insurance if they really think they need it. And so a number of states had state high-risk pools already in operation, and Kansas has had one again since the early 1990s. And the board of directors that administers that pool decided at that time to take on the responsibility for also administering a PSIP for Kansas as well. The eligibility rules for those two high-risk pools are different, and they could not be blended. So they had to operate both of them sort of on a parallel track. The eligibility rules were different. The cost was different for the plans. And I think the most significant thing that I will tell you about the Kansas PSIP is, and again, this kind of gives us some insight into what may happen starting in 2014 with the health insurance market, not only in Kansas, but across the whole country. Our state high-risk pool has about 1,400 people in it, and that's been a pretty steady number for a period of time. The premium rates, if you're going into the high-risk pool, are higher than you would pay if you were buying insurance out in the private market. And but you know, the people get in there. I mean, the people that we have in our state high-risk pool, these are people who have serious heart conditions or diabetes or cancer or sickle cell anemia. These are people that have very serious health conditions that require constant care. And over the history of that state high-risk pool, we have in the last few years have been averaging. This is the explanation, kind of the idea of medical loss ratio. So for every dollar of premium that we took in from the people who were in the state high-risk pool, we paid out $2.50. And that gap in there is covered by the insurance companies. And so every year, what the pool would do, it would go and make an assessment on all the insurance companies that do business in the state of Kansas. Last year, the assessment on the insurance companies was $14 million. So, we had to take all the premiums in for that 1,400 people were in there, and then we needed another $14 million on top of that to cover their costs. The PCIP, for whatever reason, when this program came into place, we have about 500 people in the Kansas PCIP right now. Those people are individuals probably who had never had insurance before or had lost it at some point, and for whatever reason, their costs have been significantly higher than what we were seeing in our state high-risk pool. So in the PCIP, for every dollar of premium we were taking in, we're paying out $8.50. Huge, huge gap. And where that gap is, or where that gap is being covered for the PCIP, was for dollars that were allocated to the state of Kansas from the federal government. So each state was given an allocation of dollars. Ours was $35 million. And that's where, so when we would draw down dollars from the federal government every month to cover the claims that were being, that had to be paid. And by the time we got through the first 18 months of the PCIP, we had to advise HHS that we were going to, based on our projections of what it was going to cost to continue to operate the pool, that we were going to exhaust our $35 million. So that was a serious problem. We're not the only state that situation had happened to, and there are some conversations that are going on right now about what they're going to do. Yes.
Would that happen regardless of what the governor would have decided to do in terms of going along with the Affordable Care Act or not?
No, I think that would. I mean, it is part of the Affordable Care, but it is a separate program. And he was just asking about if that would have happened if the governor had taken a different approach on how we had handled implementing the Affordable Care Act in our state. Yes, sir.
Is that $35 million, is that for 1 year, or is that the estimate going forward?
That was for 2.5 years. That was an allocation that was supposed to be used for Kansas.
Figure it's going to cost per year from now on.
Well, the program actually ends at the end of this year, because in 2014, when all the rules change, these folks will be able to get coverage out in the private market. But for right now, so yeah, this program will only last until the end of 2013.
And how about the exchanges? How are they likely going to operate in Kansas?
We're going to talk about that a lot. Okay. So anyway, that is significant because, as I was just saying, those folks that are in that PCIP, along with the folks that are in our state high-risk pool now, all of those folks are going to be moving into the private health insurance market along with all of the rest of us who have health insurance. So, when we're thinking about introducing this population who has obviously very serious health conditions and very expensive care that's required on an ongoing basis, those costs are now going to move into the private health insurance risk pool along with everybody else. So in 2014, here are the big important things that happened. Elimination of pre-existing condition exclusion. So remember what I told you what happened in 2010 with children. In 2014, that happens for everybody. So if you're somebody, an adult now, and you've had cancer in the past, you've had a heart attack in the past, right now, if you would go to apply for health insurance, the insurance companies could make a decision about whether or not they would even accept you at all. And if they did, they would be able to rate you up or underwrite you and determine what your premium rate was based on your health status or your previous health conditions. And also they would be able to do the same thing like we talked about with children. They would say, okay, for the first, even if you got coverage and you could afford it, they would say, but we won't cover you for this condition for a certain period of time. And starting in 2014, they can't do that anymore. When they give you a policy, they have to start covering all of your services effective from the day it goes into effect. Also, it's guaranteed issue, so it's the same thing like what happened with the children. Now, everybody who goes and applies for insurance on for January 1, 2014, the insurance company must accept you and they must keep you as long as you're able to continue to pay your premiums. So they can't drop you for any reason. As long as you're paying your premiums, they have to continue to cover you and whatever benefits that you need. The other thing that changes that's significant is the rating factors. So as I said, right now, when you go get, if you were to apply, they would look at your age, they would look at your gender, they would look at what kind of how healthy were you right at that minute. They would look at what kinds of services you had had performed up for you in the past and what other kinds of conditions you had. And starting in 2014, they can't do that anymore. So they are no longer going to be able to rate you on gender, and they're no longer going to be able to rate you on your health status. So in 2014, their rating factors are limited to your age, whether or not you use tobacco products, your geography, and basically what that is that's just a recognition of the fact that costs in Liberal may be very different than they are in Topeka or other parts of the state, and so there's a little bit of a rating difference depending on where you live. And then family structure, which simply means whether or not you're buying coverage just for yourself or whether you're buying it for a family. And on the rating factors, I think that's something that's very, very significant with that, and as I'm looking around the room and I'm seeing a lot of young people in this room. So I think this is important for you to understand. Right now in Kansas, the age bands or the age banding for health insurance is about 4-to-1 or 5-to-1. So what that means is that were you signaling?
Maybe go to the left or right just a little bit.
Okay.
You're right underneath that speaker.
Oh, okay. All right. Anyway, so if you were, this is just a very simple explanation, but right now, if you were a young person and you would buy a policy that cost $100, the most that somebody older could pay for that same policy would be $500, so 5-to-1. In 2014, that age band changes to 3-to-1. So it compresses that even more. So starting in 2014, if you're a young person, if the older person is paying $600 a month, the most, or the amount that a young person would pay would be $200 a month. So it's a 3-to-1, and so it brings that all in. And the way that this ended up working was it actually brings up the cost more for young people and tries to maintain that high end. Commissioner Prager was very active in testifying in front of Congress when this bill was being debated, and she tried very hard to help the members of Congress understand that compressing that age band was going to create a problem for young people. And she was not successful because the AARP also lobbied very hard to keep it down to the 3-to-1, and they were more successful than she was. So that's why. So in the end, it will end up being better. And if you're a young person, this will bring the cost up for you, which is unfortunate because the whole goal of the Affordable Care Act is to get younger, healthy people into the risk pool of people who buy health insurance. And so there's a little bit of a conflict there of what you're trying to do. Also in 2014, if you buy coverage through the exchange, and I don't know if you can see on the side there, I have exchanges, but then I have marketplace in parentheses. For 2 years now, we've been calling what is going to happen in 2014 these online websites where you can buy health insurance. We've been calling them exchanges. And within about the last 6 months or so, the federal government is now starting to call them marketplaces instead. For some reason, I think the exchange name kind of got a bad rap over the last couple of years, and people weren't. It just wasn't playing very well, I think. So they decided to change it to marketplaces. But if you buy through the exchange, and we'll talk about that more, or the marketplace, if you buy through the marketplace, if you are somebody who is up to 400% of the federal poverty level, and I'll give you some indication of what that looks like on a later slide, you will be able to may potentially be eligible to get tax credits and subsidies to help you pay premiums to buy health insurance, and also to cover any of your out-of-pocket costs, or your deductibles, your co-payments, your co-insurance. And again, we'll talk about that a little bit more. The other thing that happens in 2014 is there will be mandated coverage for essential health benefits. And so what the law was trying to do was it was trying to create a standardized benefit package that would be sold to everybody who buys in the individual or the small group market. So the small group refers to employer groups that have less than 50 employees. And this essential health benefit package, and I have a slide that will come right after this, will show you what's in there. I think when you see it, you'll not be overly surprised. It will be some things that you would expect. hospitalization, outpatient care, lab work, and those kinds of things. But anyway, starting in 2014, all plans sold inside the marketplace or outside the marketplace in the individual and small group will have the essential health benefits package that's been established for Kansas. There will also be a uniform explanation of benefits and standardized definitions. And I think from a consumer perspective, I think this is probably one of the most important things that happened. You know, if any of you have ever had to go and try to buy health insurance on your own right now, in the market right now, if you go look at plan A, B, and C from 3 different companies, you would, the explanation of what benefits were offered and how they were described and how they were defined was different, would be different from plan A, B, and C. And as a consumer, you're trying to figure out, well, what does this mean and what does this mean and why are these different and how can you compare them when you don't understand what it is. So in 2014, all of the plans that are offered for sale, there will be a uniform explanation of benefits. So every plan that you see, they will use the same terminology, the same definitions, and the same explanation of what the benefit is so that you actually can do an apples-to-apples comparison and not have to try to figure out what's different about these. So from a consumer perspective, it does make that a little bit easier to shop. Also, the other big controversial thing that kicks in 2014 is the individual mandate. So this is the mandate that says, starting in 2014, everybody up to age 64, because at 65 you can go into Medicare, so it doesn't apply to them, but has to have health insurance. And if you do not have health insurance, then you are subject to a penalty. There are some exemptions to this. There are some religious exemptions to this. American Indians are not subject to the mandate, and also based on your income, you may not be subject to that mandate penalty as well. But in general, everybody has to have coverage in 2014. And the penalties are for the first year, for the 2014 year, are $95 or up to 1% of your income. That increases to $395 in the second year, goes up to $675 in the third year, and will continue to grow over time. But that first year, it's a pretty low threshold. And I think one of the things that I always tell people, as the health insurance regulator organization for the state of Kansas, we are very concerned about the mandate, because if you're changing all these rules for health insurance companies and you're telling them they have to take everybody, if the only people who go buy health insurance are people who are sick and have a lot of high cost benefits that they need to use on a regular basis, I think we all understand what's going to happen to the risk pool that we all participate in, for those of us that have health insurance now. And so the goal is to try to get young, healthy people into the market as well, so that risk is spread. Now, I always tell people, insurance is a game of numbers, and the more people you have paying in premiums, the more that risk and that cost is spread out over everybody. It's like what we do with car insurance now. Everybody has to have it, and so there's all these dollars coming in, and some of us are more careful or more lucky than others, and so some people have accidents and some people don't, and that kind of evens out the cost. The idea behind this is that it's the same sort of theory, that you get everybody into the market, you spread that cost, that there be some healthy people, some not so healthy. So when I was talking earlier about the 3 to 1 age bands, if the goal is to get younger, healthier people in, we kind of sabotage that a little bit by setting their rates at a higher level. Now, the theory is that those folks, if they're younger and healthy, they may also have lower incomes, may be able to qualify for the tax credits and subsidies to help them pay for health insurance. So if that's the case, maybe that moderates a little bit of that concern we have. But that's the general theory on this. Yes.
If the governor chooses not to expand Medicaid, will this penalty apply to very low-income adults?
I'll tell you,
They can't afford insurance now.
Yes, that's going to be a very interesting question, because the law, when the Supreme Court came out and made the decision that states were not going to be required to do the Medicaid expansion, I think that threw the folks in DC for a loop, because that was not that they did not expect that at all. So the expectation was you were going to have people up to 138% of the federal poverty level covered in Medicaid, and then everybody else would go into the exchange up from there. There's a little bit of an overlap. But that population, if you don't do Medicaid expansion, you're absolutely right. They won't qualify for Medicaid with no expansion, and they do not, up to 100% of federal poverty level, they do not qualify for tax credits and subsidies. So they can't even go out and buy private health insurance with assistance. So there you have this group, what I refer to, this is the poor individuals who are sort of stuck in the black hole of no options, which in some cases is what they have now, unfortunately. But yeah, it's a little hard to imagine that you can make them subject to the penalty when that situation that has arisen as through no fault of their own. So, yes, sir.
Let's see, the only way this is not going to skyrocket healthcare costs is if we get young, healthy people in it. So what kind of penalties will there be for no coverage? Because if it's like, I've heard some suggest that if you don't have coverage, you have to pay a $2,500 copay, which if I'm going to be charged $5,000 a year to pay into the system, and I've got a $2,500 copay if I don't have it, it's going to be very hard not to choose to not have health insurance.
Yeah, and that's what I was saying. You know, the penalty is $95, and I always tell people if you're somebody who's young and you think you're pretty healthy, and I don't really think I need this, and I'm kind of willing to take my chances on it. You know, it doesn't take a genius to figure out that you cannot buy a year's worth of health insurance for $95. So, you know, the expectation is there are going to be a lot of younger, healthier folks who are just going to say, I'll just pay the penalty, at least for the first year, and then see what happens. But again, as I said, if you're a young person and your income is fairly low, it may make sense for you to go into the exchange and take advantage of those tax credits and subsidies to help you cover those costs. And so, you know, depending on how low your income is, you can come very close to getting a lot of your costs covered for your health insurance, depending on what your income is. And obviously, each person's going to have to look at that individually. But it's going to be it's going to be interesting to see how this plays out, because until we really start to see the numbers, we're not going to be sure.
I mean, if it's required by law, I'll get it, but somebody with less moral values may decide to stick it to the elderly.
Right. No, you're right. You're absolutely right. Okay, so the establishment of the online marketplace, formerly the exchange, so that, and we'll talk about that a little bit more. So this is the essential health benefit category that I was telling you about. These are the 10 categories that are actually laid out in the law. And again, there are things that I think most of you would recognize: outpatient surgery, ER, prescription drugs, and the couple of things that were added to this list that don't currently exist in plans that are sold right now. And actually, I'm going to add one extra. Right now, if you're in Kansas and you buy a policy, you don't have to buy a policy that has maternity and newborn care in it. Starting in 2014, all plans will have that in there. Also, the other couple of things that came into place was habilitative services, and honestly, for a long time, none of us really quite understood what that was, and I don't know that we still understand. But it's similar to rehabilitative. So when you have rehabilitative services, if you get injured or sick and you lose some of your physical capabilities, you go to rehab, physical therapy, speech therapy to get those back. In habilitative, the idea is it's the same type of services, except that you're getting them to gain something that you never had in the first place. So they're trying to improve your health because you already, I mean, you from the very beginning you never had those abilities. So that's kind of the explanation there. And those services will mirror rehab services. The other thing is that's been added is pediatric services. So all of the plans that are sold will have both dental and vision care for children.
Bill 2 services is an example, like if you have a child that's born that has autism, they would be fully covered under one of these?
You know, that is the big question, because right now in Kansas, that is not, those autism services are not something that's offered. And so that is not part of the benchmark plan for Kansas right now, because those services were not currently being provided. Now, you know, if you have an autistic child and you know, and your doctor decides that that child would benefit from speech therapy or something like that, which is a typical service that's provided in a rehab, I think arguably you could say that your child ought to be able to get access to those. But the types of services that are specific to autistic children, those services are not included in that habilitated definition, or at least not at this time. Was there any other? So this is just some general information about Kansas and insurance now. So right now we have about 365,000 people in Kansas who are uninsured. It's about a little over 13% of our population. Right now, as you can see, almost half of our population get their insurance through their employer. So it's an employer-sponsored coverage. There are about 20, almost 30% who are getting coverage through Medicare or Medicaid or other types of public programs. And then there are about 5.5% of people who get coverage because they just go out and buy a policy on their own, an individual policy. And then this is talking about the Medicaid expansion. So Kansas has one of the lowest thresholds for Medicaid coverage in the entire country. So right now, in order to qualify for Medicaid in Kansas, your income has to be less than 32% of the federal poverty level, which is very, very, very low. And if you're an adult, a childless adult, you have no chance to get health insurance at all. And that's why it says currently childless adults who are not disabled cannot qualify for Medicaid at all. And we think that there will be about 380, right now there's about 380,000 Kansas adults and children that are enrolled in Medicaid or CHIP, which is the Children's Health Insurance Plan. So that's currently enrolled. If the state were to do the Medicaid expansion, that would expand eligibility to all adults, even childless adults, earning less than or equal to 138% of the federal poverty level. So for a family that's a little over family of four, a little over $32,000, and for an individual, almost $16,000 a year. So that would expand. You remember before it was less than 32% of the federal poverty level. Now we're going up to less than or equal to 138. So it brings in a lot more people. And as you can see, it's we expect more than 240,000 Kansans would be expected to enroll in Medicaid if the expansion actually happened.
And if Kansas, the federal government would have no obligation if Kansas elects not to expand, is that correct?
Right. That would not happen if the state chooses not to do it. Okay, so some other things, and these are just things to think about in terms of what would happen, and what other things happen as a result of not expanding Medicaid. One of the things that happens is right now in Kansas hospitals, like hospitals all over the country, because you have so many people who go to the hospital to get care and they don't have health insurance and they're not able to pay their bills when they leave the hospital or finish with their care, two things happen, and I always like to give this opportunity to explain this because I don't think people realize this. One of the things that happens is the federal government, for those hospitals who incur a lot of that uncompensated care, the federal government pays these hospitals some money to try to help them recoup some of those dollars that they're losing because they don't get paid for that. And so in the way the law was written, again, because the law was written with the understanding that uncompensated care would reduce because everybody would either be in Medicaid or they'd have private health insurance. The law anticipates that those disproportionate share payments, we call them DISH, would start to go away. So they would stop giving that money to the hospitals because it wouldn't be needed if you had everybody covered. And so that is something right now, there's some discussions going on in Congress right now about whether or not they want to try to modify what's supposed to happen in the law because of so many states who are potentially not going to take up the Medicaid expansion. And of course, those hospitals are very concerned if they're not going to get Medicaid expansion, they still need those dollars because there are still going to be people that are going to need care and they won't be able to pay. One of the concerns that I know the people in Kansas have, and again, some of you may or may not be aware, but the way that Medicaid is done in the state of Kansas changed on January 1 of this year. And in the past, the way the state has handled it is now moved to a managed care system so that care is being administered and provided through private companies instead of directly through the state government. And that new procedure has only been in place since the beginning of the year, and it's been a little rocky. And I don't have any particular concerns about anything specifically, but regardless, at any time you change a system, there are going to be problems. And so the idea of expanding Medicaid and moving a whole lot more new people into this new system potentially, you can kind of see that may cause some problems when they're already struggling to deal with the people they already have enrolled. So that's certainly something to think about. The state cost for expansion. So for the first 3 years, of the Medicaid expansion, so 14, 15, and 16, the federal government will cover 100% of the cost for that expanded population in Medicaid. Starting with the 4th year, that starts to phase down, and so it becomes less, and the state starts to pick up part of that cost. Ultimately, by the time we get to 2020, it's at about a 90-10 match. So the federal government will pay 90% of it, and 10% of it will be covered by the state. So it's a reasonable concern to say if you're going to expand this medication in a few years, the state is going to have to come up with those extra dollars to cover that 10% match.
So if Kansas elects to never participate in maintaining private free companies that administer Medicaid, that's all coming out of the pockets of the customers, or is it just the state of Kansas?
Well, right now the match, on Medicaid right now the match is 60-40. So right now for the program we're operating currently, 60% of it is covered by the federal government and 40% of it is covered by the state. So there's always been a state match in that, but that would continue. That 60-40 for this existing population would continue. The other thing that's of interest is that there have been some states that have said, well, we may not do it this first year, but we'll think about it later. And the one thing that the states just have to be aware of is that 100% match for 3 years, that's not a rolling 100%. So if you opt out the first year, if you come in the second and third year, you only get 2 years of 100% match. It doesn't start at 100% with when you come in. So if you waited too long, you'd be starting at the 90-10 match right away instead of getting the benefit of 100% match. Also, some concerns about public awareness of the changes and who might be eligible. And then, again, some of you may or may not be aware, the state right now is in the middle of building a new electronic eligibility and enrollment system. It's actually going to be a real state-of-the-art system. It's going to be something very impressive. But that process is ongoing, and the idea of expanding Medicaid and starting, expanding it at the time when you're also introducing this new electronic system. Again, there's some reasonable concerns about how that might work out. So, the marketplace. So under the Affordable Care Act, each state will have a marketplace, formerly known as the exchange, on January 1, 2014. And if the state has chosen not to operate the marketplace, the federal government will operate it, and that's what we will have in Kansas. Kansas will have a federally operated marketplace, this online marketplace. And Kansans will have the opportunity to buy insurance or to determine whether they're eligible for Medicaid assistance through that marketplace, and I'll explain that a little bit more. Right now, there are 17 states in the District of Columbia that have decided to operate their own state-based exchange or marketplace. There are 7 states that entered into a partnership with HHS, and so they are performing some of the functions for the marketplace, and then there are 26 states that have opted to have the federal government run the marketplace, and obviously we're one of those 26.
Will there be opportunity, will some insurance companies still be selling outside of that marketplace?
Yes, they will.
And I can choose to purchase
Outside of the marketplace, yes you can. So people who buy through the online marketplace, who are eligible for a public program like Medicaid, will be able to get enrolled in that program. And then I talked about this basic concept is like Expedia or Travelocity. And this has actually kind of become a joke. This was something that they started talking about early on about, the exchange is like Expedia or Travelocity. And it's actually much more complicated than that, but it was a way to sort of start helping people understand what happened. So, right now, if you go on Travelocity or Expedia and you go in and you put your information in, you say, I want to go to Houston on this day at this time, and 3 of my family members are traveling, and you put all that information in and you hit search, and it comes back and it gives you a list of all of the flights that are around, where you want to go, the time you want to go, and it shows you the cost, and then as the consumer, you pick what you want. And that, that's in general the way the marketplace will work, but obviously it's much more complicated than that, because buying health insurance is not as simple as buying a plane ticket. So, and there's a separate piece of the exchange that makes this a little bit more complicated. And again, really short explanation of it, but what will happen is if you're somebody who decides you want to buy through the marketplace, what you will do is you'll go on to the internet, to this website. It'll ask you to put some information and set up an account for yourself. So it'll ask for your name, your address, information. It will also ask you about ask you questions about your income. And specifically the first question it'll ask you is what your modified adjusted gross income was for the previous tax year. So for people who are enrolling later this year, you'll be using your 2012 modified adjusted gross income, or MAGI, and you'll put that number in. And based on the information that you submit, the internet, it'll go up, and there is something called a federal data hub, and that information you put in will go up, and it'll hit this data hub, and it will say, yes, we recognize Linda Shepard. Yes, she is a U.S. citizen. No, she's not incarcerated. And yes, that MAGI she put in was in fact her MAGI for last year. So the data hub has Homeland Security information. It has Social Security information. It has IRS information verifying you have to be a U.S. citizen to buy coverage through the marketplace. And it will come back and it'll say, okay, Linda Shepard, based on this information, we think you qualify for this program, whatever it is. Maybe it's Medicaid, maybe my children qualify to go into the Children's Health Insurance Program, or if I don't qualify for those, it'll say, based on your income, you qualify to get this much money to help you buy private health insurance, and it'll tell you how much you get. Or it'll say you don't qualify for any of those, but you can go ahead and go into the marketplace now and look at the plans that are available in your area. So you will have put your zip code in, so the system will know, show me all of the plans. I live in Lawrence. Show me all the plans that are available to me because I live in Lawrence. And then when you do that, you'll be able to see your plans. If you're somebody who has been determined to qualify for Medicaid or CHIP, there'll be another part of the internet that you'll go off to and try to get enrolled, work with the Medicaid folks to get you enrolled in that program. If you qualified for tax credits or subsidies to help you buy private health insurance, when you're looking at the plans that are available to you, for example, if it says this plan, you pick one and you say, I think I'd like to buy this plan. The premium for that plan is $400 a month. But when you went through the eligibility process, it said you qualify for $250 a month to help you pay for that insurance policy. So what will happen is if you enroll in that plan, the federal government will send, ABC company $250 a month. You pay the other $150 and you get your insurance. So it's paid for you ahead of time. At the end of the year, when you file your taxes, the IRS will know that you took this tax credit throughout the year, and then that would be done in the calculation of when you do that, where your taxes that year. And one of the things that I think I had told, and I mentioned this to this gentleman that asked me earlier, if you're someone young enough and your income is low enough, potentially that tax credit that you get to buy, that you might be eligible for, might come very close to covering the entire premium that you might owe to buy health insurance. Yes.
I'm real young, real healthy. I pay a $95 penalty, and a catastrophe, problematic situation.
Right.
I still go in the emergency unit. They still expect me to pick up my catastrophe.
Yes, because you won't have insurance.
They're still obligated to do that.
Yes, they are still obligated to do that. So anyway, this is kind of a timeline for the marketplace. In Kansas, the insurance companies were able to start submitting applications to be on the Kansas marketplace. And again, it's the one that's going to be run by the federal government. They were able to start doing that on March 29th. All of those applications were due on May 1st. The insurance department, that's what the kids' insurance department, we will have about 3 months to review and approve those applications. And then once we approve all of that, we have to submit all that data up to HHS so that can all be loaded on this federal website that shows the plans that the companies are selling, what the rates are for those plans, and that information has to be submitted by July 1. Open enrollment begins on October 1st and ends in March 31st. If you were to go on the exchange on October 1st and enroll in a plan, that plan doesn't become effective until January 1 of 14. So all these plans that are being sold during this period of time kick in for January 1 of 14. So if you go on early, you would have to understand that that's not something that's going to be effective right away. Yes, sir.
Should the last date be 2014, the March date?
Oh, yes, I'm sorry, you're absolutely right. My mistake. Yeah, so March 31st, 2014, that's exactly right. And one thing I want to say about this, and I'll get to your question in just a second. One of the things I want to say about this is, if you're somebody who says, I'm still trying to make up my mind whether I want to buy insurance or I just want to wait, remember at the beginning I said it's guaranteed issue. So if you go and apply, they have to take you. But if you don't go in and buy during this October 1 to March 31st time period, you'll have to wait until the following year to have that opportunity to buy health insurance. That was something that the insurance companies requested because they didn't want this situation to come up where, let's say, I decide, I don't need insurance. And then sometime after March 31st in May of next year, I go to my doctor and he says, I'm sorry, Linda, but you have some serious health condition that's going to require a lot of care. And then I would immediately rush out and get on my phone and call my insurance company and say, I need insurance right now. I need it right now. And you can't, and I think people understand this. I mean, you can't do that when you have car insurance. You can't call the auto company, their auto insurance company, and say, I just wrecked my car, I need insurance. And you can't do it when your house is on fire. So it's the same idea. Why would you let somebody do that with health insurance? Let them wait until they're sick and go buy coverage. So if something happens to you between March 31st and when the open enrollment period for the next year starts, you'll be out of luck. So there was a lady up here.
When will the decision be made about the Medicaid expansion?
I wish we knew. The governor.
Before the enrollment?
Excuse me?
Before the enrollment?
Well, the governor has not indicated when he's going to make that decision. And the truth of the matter is, if it's not made fairly soon, I think we would definitely be out of luck for the 2014 plan year, just because I don't think there would be enough time to get this in place. Because once that decision's made, he will have to let HHS know. We'll have to make sure that, the eligibility and enrollment system, that new IT system I was telling you about, making sure that that's ready to go and that everything's going to work fine. I mean, there's some things that would need to be done. So it's not like you could just make this decision at the last minute. But right now, the governor has not given us an indication of when or if he's going to make a decision about that. And, yes, ma'am.
If someone were to enroll after January 1 or March 31, will it be effective first of the next month or a specific date?
I'm going to tell you, and I'm glad you asked me that question because it reminded me of something I wanted to check. I think my understanding is it would be effective the first of the month following. Depends on when in the month you apply. So if you applied, let's say you applied on March 10th, your coverage would be available in April. But if you waited until March 20th, then it wouldn't be, it'd be May 1. So if the 15th of the month is the cutoff. If you come in before the 15th of the month, it'll be the next month. If you wait after that, it'll be the next month. So again, that's another thing to keep in mind if you're trying to get your coverage to go into effect by a certain time. So as I said, the marketplace has to be interoperable with the Medicaid eligibility system, because ideally the way this is supposed to happen is you go on the marketplace and if you're determined to be eligible for Medicaid, it will take you to that Medicaid eligibility system to determine your participation. Obviously, all the insurance companies that will be operating on the Kansas marketplace have to be approved and licensed by our department, and we'll continue to have regulatory oversight of those companies. This I'm just going to share with you. These are sort of the 5 core functions for the marketplace. So, and again, consumer assistance, I think we all understand what that is. Plan management, that's just that piece that I was talking about that our department will be doing. So that's us looking at those plans and those rates that are submitted to us and approving them and making sure that they comply not only with federal law, but also with all of our Kansas laws as well. The eligibility and enrollment system, again, that's the whole, that's the website, the ability to actually get enrolled through the website and to determine what programs you might be eligible for. And then financial management, that's just kind of the cost side of this. So how much are you going to charge the companies that are selling on the marketplace, and how are you going to deal with some risk adjustment between the companies in case some of the companies get a whole lot more sicker people than some of the other companies. And it's a very complicated system, and that's one of those things I could probably talk to you about an hour just on that.
Now, who would be responsible for that disparity of the state? If some companies get overloaded with sick people.
No, the law has a whole risk adjustment system built into that. All the companies will be paying dollars into that, and then whichever company takes the biggest hit, the dollars will be shifted back and forth between them to try to even that out. So anyway, the marketplace, I keep referring to it as marketplace, but it's actually two things. It's the individual exchange for people who are just going on to buy coverage just for themselves or for yourself and your family if you don't get coverage through your employer. And then there will also be what is referred to as the shop exchange, which is where small employers can go on and buy coverage for their employees. The law defines small employer as 1 to 100. And I think this is important. 1 is defined as the employer plus 1 employee. So if you're a sole proprietor, you have to go to the individual exchange. You can't go through the shop. The state can elect to define a small group as 1 to 50 until January of 2016, and Kansas has done that. So for us, the small group will stay at the 1 to 50. And beginning in 2015, the employer will actually be able to. Right now, if you're an employer group, you offer a plan to your employees, and you go and you pick a plan, and you go to your employees and say, this is the plan you get. If you want to enroll in this, everybody enroll in it. Starting in 2015, through the shop, the employer will actually have an opportunity to be able to go to your employees and say, I will pay $300 a month for you to buy, a plan in the exchange, and they'll pick maybe 3 or 4 plans, and they'll say, you take that money and you go pick which plan you want, and so the employees will have more choice and will be able to look at those options just like as if you were going into the individual exchange.
If I do not want to be part of the exchange marketplace, I can sell, I can be an insurance company, sell whatever I want, completely at my discretion, so I can control as to how fair I am in providing information. Like I have a $25,000
Deductible. Right.
I can do whatever I want.
Okay, let me clarify. The market outside of the marketplace will continue. So even after 14, if you want to go into the marketplace, you can do that. If you don't, you could go to an insurance company just outside and say, I just want to buy this plan, and I don't want to go through the marketplace. Maybe I don't want to participate, or maybe I don't think I'm going to qualify for any assistance anyway, so I'm just not going to worry about that. So there will be plans. Now, the thing you have to remember is the plans that are sold both inside the marketplace and out all have to have the same benefits. So the benefit package will be the same. The comment that you made about this is what we refer to as cost sharing. So there will be different plans both inside the marketplace and outside the marketplace. So you may have all of those essential health benefits, but your deductibles may be different, your co-insurance amounts may be different. And as a consumer, you just have to decide how much risk you're willing to take on to do that. Yes, ma'am.
If a business has insurance, pays part of the employee's insurance, what if some of the employees want to go through an exchange, but the others are happy with the plan that the company offers? How would that be handled?
Okay, you're so good because you put me right into my next slide. So here's what happened. In 2014, if you're a small employer, like I said, less than 50 employees, you have no obligation to provide insurance for your employees. There are a lot of small employers that do offer coverage for their employees, but in 2014, there's no requirement that they have to. So if a small employer doesn't offer coverage now, they don't have to start offering. If they offer it now, but they decide in 2014 they don't want to do that anymore, they can stop, and there's no penalty on the employer. Then you have to remember, though, is all those individual employees still are subject to that individual mandate. So you still have that responsibility to go out and get insurance for yourself, but it may not be through your employer. If you're a large employer and you already have a plan, so here's 2 scenarios that could happen in 2014. In 2014, if you have 50 or more full-time equivalent employees, you have to offer coverage to your employees, or you're subject to a penalty. And the penalties come up in one of two different ways. First of all, if you're a large employer and you don't offer coverage for your employees, and at least one of your employees goes to the individual exchange and qualifies for a tax credit or a subsidy to buy health insurance through the individual exchange, you, the employer, will be subject to a penalty of $2,000 times the number of employees you have minus the first 30. So if you have 70 employees and one of your employees goes and gets a tax credit or a subsidy, your penalty is $2,000 times 70 minus 30 times 40 employees. So that's one scenario. The next scenario is, and this is closer to what you were saying, if the employer does offer coverage, but you have to do two things if you offer that coverage. You have to offer something called minimum essential coverage, and that is again, very kind of complicated calculation of what constitutes minimum essential coverage. You have to offer minimum essential coverage, and you have to make the amount that you make your employees contribute to paying for that coverage has to be less than 9.5% of their salary. So it has to be affordable. That's the percentage that they're using as affordable. So if you offer coverage and it's minimum essential coverage, and the amount that you ask the employee to contribute to pay for that coverage is less than 9.5% of their income, then you, the employer, have met your requirement. But if you don't do that, if you offer coverage but it's not affordable for all your employees, and one of your employees go to the exchange, they opt out of your plan and they say, I can't afford this, it's over 9.5% of my income, then the penalty is $3,000 for each employee that actually goes and gets the tax credit. And again, there's a complicated calculation up to a maximum of 2,000 times the number of full-time employees minus 30. So it's the greater of $3,000 times employee or the other option. The thing that I always want to tell employers about this that I think is important is if you have an employee and you say, your amount that you have to pay every month is $150. And that's actually less than 9.5% of their income, but the employee says, I don't want to pay that much. I'd rather go to the exchange and see if I can do better there. When they go to the exchange, they may, and it's going to be interesting to see how the IRS handles this, they may be able to, because one of the questions they're going to be asked during the eligibility system is, are you eligible to participate in employer-sponsored insurance? And if the answer to that is yes, then technically they're not eligible to go on to the exchange and get tax credits or subsidies as long as that is affordable. But, if the question, I don't know how they're going to ask the question, but if they say, is this less than 9.5% of your income, and the employee doesn't tell the truth about that and goes ahead and gets the coverage, what will happen is in the next tax year, so early in 2015, the IRS will go to me, the employer, and say, you owe the penalty for this, and this employee. But the employer will have an opportunity at that time to say, no, wait, I offered affordable coverage, and so you, the employer, will be off the hook because you'll be able to show this is what I offered. The downside for the employee who tries to do that is those dollars they got for that tax credit for the prior year will all be owed back to the government. So it's not if you're thinking that you can just get away with that on the side, it's going to catch up with you. Yes, ma'am.
My husband's place of employment is going to start putting on their pay stubs how much the company pays for the insurance to prove that they are less than the 9.5%.
9.5%, right. Okay, so anyway, this is just kind of a recap of what I was talking about. So in the individual small group, they won't be able to rate you on your health status anymore. Maximum age banding variation of 3 to 1. You can get, on the tobacco use, you can get charged up to 1.5 times the amount you would be charged. There will be rate variation based on geographic area, and then your family rate is based on the age and tobacco of each member of your family. So even though you go and you say, I want to buy a policy for my family, they'll actually look at each person in the family and look at how old they are and whether they use tobacco products, and then they'll build a rate for the family based on looking at the individuals. This will be a single risk pool in the small group market and individual market, and that's for plans. So all plans that the company sells in the individual market, both inside the marketplace and outside the marketplace, they have to pool all of the dollars that they take in for premium and all the losses they incur in one pool. So whoever goes into the pool at that time, no matter whether you're in or outside the marketplace, it all goes in together. And then, as I said before, the 3-to-1 age banding will significantly impact rates for younger, healthy enrollees in most states. I've said this before, all the individual and slumber plans have to include the essential health benefits. These cost sharing levels, this is, when you go on the exchange, if you go there, you will have an option to buy a bronze, silver, gold, or platinum plan. And the higher you go up in the precious metals, the higher your premium will be, but the less your out-of-pocket cost will be. So if you buy a bronze plan, that means if you use services for a year's time, in general, the company would be paying 60% of that, and you as the insured person will be paying 40% of that out of your pocket in your deductibles and your co-payments and co-insurance and like that. So if you're somebody, again, if you're somebody who's relatively young and healthy and you aren't worried about incurring too much cost, it might make sense for you to buy a bronze plan, because obviously the premiums will be less. But if you're somebody who has some serious chronic, or either not so serious, just chronic conditions, you have to take a prescription on a regular basis, you may want to buy a silver or gold because you already know you're going to incur some costs because you're going to be using those services throughout the year. There will also be a catastrophic plan available, and that's limited only to folks who are under the age of 30, and then also is available for people who can't afford other options that are in the marketplace. And that catastrophic plan, again, it's going to have really high cost sharing if you actually incur a lot of coverage. But again, if you're somebody very healthy and you think, I just want to be able to go to the doctor when I'm sick a couple of times a year and get my my preventive test taken care of, that might be a good option for you if you are not worried about having to use very many services. But again, that's only limited to young people. And this just goes on after 1 o'clock. Okay, well, I'm going to stop. So if there's anything else I haven't said, I mean, I apologize. I always feel like I'm up here talking 90 miles an hour, but there is so much to talk about in this law that it's just very difficult. Yes, ma'am.
Is there a website with this information somewhere?
There is, if you go on our website, it's www.ksinsurance.org. I think maybe I have it on my last slide here. Yeah. There is, when you go to that website, if you look right over to the right-hand side, you will see there's a little special box that says healthcare reform. If you click on that, it will take you to an area where we put all kinds of information about the Affordable Care Act, the various things that have already happened, and some information about what's going to happen in the future. And obviously, if you have any particular questions, that commissioner at ksinsurance.org, that will come into the department, and all of those emails come to me, and so we always try to get everybody answered if you have specific questions about things that you would like to know more about. Yes,
What happens if you move to a different state?
If you move to a different state, what will happen is you'll have an opportunity to enroll in that into that state's marketplace.
Or would you still be covered by the Kansas one?
No, you would be shifting. So you would be terminating your coverage in the Kansas one. You'd be moving over into, let's just say you crossed the line and moved into Missouri. You would then be enrolled in a Missouri plan, and you'd have that option like right when you first moved, so you could have continuous coverage.
So when is it we can actually look at actual rate numbers?
On October 1. 2013. That's when that is the first day that you're supposed to be able to go on that website and start shopping.
Are you talking about this Kansas website?
No. That's just our department's regular website. There, right now, we do not know what the internet address is for the marketplace. Yeah, we don't have that yet.
It's not healthcare.gov.
It may be. We don't know exactly for sure if that's the way it's going. We think that you'll be able to get to it through there, but there may actually be a direct URL that you'll be able to use. There was someone else that had a question.
The marketplace providers, are they all going to be Kansas insurance providers, or are we going to sell across state lines?
No, it'll be just like if you were buying now, and if you go and you buy a Coventry plan, you'll be using their network, whoever their providers are. All the companies will have their networks. Yes,
I
ma'am.
noticed on your slides that May 1st was the deadline for them to submit. Do you have any idea how many did?
3 companies.
Okay, 'cause I wondered.
Yeah.
So it's only 3 expand can.
Yes. 3 on the marketplace. There will still be more companies selling outside of the marketplace, but 3 on the marketplace.
So outside of the marketplace, where the companies are still able to keep doing things, will they be able to?
Well, I mean, they still have to follow all those same rules, so they still have to use the 3-to-1 age banding, they still have to, it's still guaranteed issue, it's still no pre-existing condition, yeah. You know, truthfully, the main advantage to going into the marketplace is if you're somebody who thinks you could qualify either for Medicaid or to get assistance paid for private health insurance, that's really the draw for going into the marketplace. Because that's, you know, if you're somebody who hasn't been able to get coverage because you can't afford it, that's where you go.
So if that's the case, will people be able to go if they find out they really don't have to, they don't have to pass that much for the deadline, because they go to any private insurance company?
No, because that open enrollment period applies both inside and outside.
But if they're not buying, oh, okay, so these insurance companies won't be taking any policies between March 31 and their, October.
Until the next.
They won't be taking any applications.
Right.
Oh, that's good.
Yes, ma'am.
Do you know, like, our university offers health insurance for students? Will that plan cover, is that considered private? Or
You know, the Affordable Care Act actually made some changes in the way that student health insurance is provided. Our expectation is that will continue in the future. But again, you know, if you're a young, healthy person, you know, I don't know, you know, I don't know right off the top of my head what it costs you or your family to buy for that student health insurance. But the truth is, you may come out ahead going on the exchange.
And there are no exclusions. If you're over 26, can't get any parents' health insurance, and you're a full-time student, they're still eligible for this.
Anybody's eligible to go on the exchange or the marketplace. Yes,
So
sir.
a bit of a fundamental question. The Affordable Health Care Act, also known as Obamacare, was promised as insurance reform that would ensure everybody have health insurance and lower premiums at the same time. Do you believe it's going to deliver on that promise, or are the critics right that that's going to cost us way more than expected?
Well, 2 things. First of all, the fact that if the state chooses not to do Medicaid expansion, as I said earlier, we're going to have this black hole of folks who are not going to be able to be covered. So that's one issue. The cost issue, you know, Commissioner Prager has been very open in her comments when she goes out and speaks, and I say the same thing too. The reality is premium rates are going to go up. You are asking the insurance companies to change, basically completely change the way they do business. You know, they can't underwrite, they can't pick and choose who they cover. They have limitations on how they rate the plans. I mean, those things are going to cause them to have to redefine how they determine what their risk is. And there are going to be increases in premiums. Now, you know, clearly the intent of the Affordable Care Act was if you get everybody into the market, then eventually you start to get rid of this idea of uncompensated care. And I think, you know, I think that's one of the things that I always try to tell people. You know, right now, when we're talking about all these people that go to the hospital or go to the doctor and they get care and they don't pay. Well, if you're a hospital, you know, you just don't offer that for free. I mean, you have to get your costs covered at some point. So what the hospitals do is when my insurance company goes to that hospital the next year and says, we want to enter into a contract with you to cover our people that enroll in our plan, the hospital does their calculations and they figure out that they need to add a certain amount into the amount that they charge my insurance company to cover that cost. So that cost shifting is happening today. Any of us here who have health insurance, we are paying for people who don't pay for their own health insurance already. So the idea of the Affordable Care Act is you get everybody covered, and that way you start to eliminate that cost shifting that's happening to all of the rest of us. So somebody's paying for that coverage. It's just a question of who and how it's being paid for. So, you know, is this going to be the fix in 2014? Probably not. In the long term, potentially it could be. But we are on an experiment. It's yet to be seen.
We were on target for 18% increase a year. Had we done nothing, believe me, we would pay more if we had not done anything.
Yeah, right. And again, I think that's something that everybody says. That the projections for what was gonna happen in the future, it's not sustainable for any of us.
More premiums and less coverage.
Right. So something had to change. Now, whether or not this is the answer, it's yet to be seen. But it's somebody trying something, and we'll see what happens.
One more question.
What is the difference between CanCare, Medicaid, Medicare?
Okay, CanCare and Medicaid are the same thing. CanCare is just the new name that we call it in Kansas now. So it's still the Medicaid program. CanCare, that was the name that was changed when instead of having the state sort of administer that program, now we have these 3 insurance companies that do it for the state. So that's CanCare. CHIP is the Children's Health Insurance Plan, so that is a separate program. Again, it gets federal dollars, and it is only available for children. So your children may qualify for CHIP, but you as the adult, the parent, may not qualify for Medicaid, and you may not have insurance at all. And then Medicare obviously is the program for seniors. So when you turn 65, you go into that program, and obviously that's a government contributed program as well.
Thank you very much, Linda. A hand thrown in the